Shortness of breath, chest tightness or pain, wheezing upon exhaling, coughing. These are some symptoms of an asthma attack. You probably know someone who suffers from asthma. They may be a friend, family member, coworker, student, or even yourself. In the United States, it is one of the most common chronic diseases. 28 million Americans have asthma. That is about 1 in 12 Americans, more than 6% of children, more than 8% of adults. More than a third had at least one asthma attack in the past year. For children under 5, it was more than half. Asthma causes, triggers, and treatment plans are individual. It may take some effort to find what helps. With a little background information and support from friends and family, patients can breathe a little easier. I'm Wanda Frazier. This is Your Body and You. In general, neither asthma nor asthma attacks are reportable to the CDC. Some states do require reporting of work-related asthma, WRA. Much of the tracking of work-related asthma is done on the industry level. Data. Asthma data is analyzed from death certificates, hospital emergency and inpatient records, literature reviews, and sample survey data, such as the Behavioral Risk Factor Surveillance System, BRFSS, and the National Health Interview Survey, NHIS. A definition. Current asthma is defined as: was the patient ever diagnosed with asthma by a health professional and reported that they still had asthma? In recent years, rates of current asthma seem to have leveled off. The highest rates are for young and middle-aged adults. On this map, the darker the color, the higher the current asthma rates. The states with the highest rates were Puerto Rico, West Virginia, and Rhode Island. Lifetime asthma is defined as: has the patient ever been diagnosed with asthma by a health professional? Overall, lifetime rates of asthma increased for younger adults. Lifetime rates for children either leveled off or went down. This image shows severe persistent asthma. South Dakota, Alaska, North Dakota, Nebraska, and Montana had the highest percentages of severe persistent asthma. A definition. An asthma attack occurs as a sudden and severe worsening of symptoms. Bronchospasms occur, airways tighten or inflame, mucus is overproduced, breathing and speaking become difficult. Asthma attacks have trended down. Children still have the highest rates of emergency room visits. Mortality. Asthma mortality has been trending down. The past few years, asthma mortality in the U.S. has ranged between 3,200 and 3,500. These images show death rates by age groups. The highest rates are for seniors in blue and middle-aged adults in red. Patients over 40 show a lower remission of asthma and more accumulated environmental and occupational exposures. By location, western states in gray and northern eastern states in red have the highest asthma mortality rates. Research attribute lowered trends in asthma attacks and mortality rates to a better understanding of asthma, improved treatment methods, and targeted treatment plans. And little background. Asthma translates to short drawn breath. 20 years ago, scientists and the medical community reclassified asthma as a heterogeneous disease. Patients diagnosed and treated 80 years ago may have been lumped into a standard diagnosis and treatment protocol. Now, asthma is considered an umbrella term of diseases that cause chronic inflammation of sensitive airways. Each type shows different pathology and benefits from different treatment methods. For example, in a school setting, each student diagnosed with asthma will have their own asthma action plan for the teacher and nurse to follow. As strange as it may seem, there are different types of inflammation that involve different aspects of the immune system. The immune system plays a major role in asthma. Something to consider: since asthma triggers are external, it is not considered an autoimmune disorder. Autoimmune disorders are triggered by and attack one's own body. Instead, asthma is considered a chronic disease of the lungs. However, some extreme cases of asthma can have autoimmune components. The immune system has several different types of cells that build a foundation for the different types of asthma. This image shows white blood cells, aka leukocytes, of the immune system. The cells that play the biggest role in asthma are eosinophils, neutrophils, and macrophages, which are made from monocytes. T cells, aka T lymphocytes, and B cells, aka B lymphocytes. Antibodies IgE and IgG are plasma cells made from B cells. Cytokines are signaling protein cells that regulate immune response and inflammation. Most of them are made by immune cells. However, during an injury, they may also be made by other types of cells. A definition: inflammation is an increased vascular permeability to recruit more immune cells, in this case, to the airways. Inflammation is primarily part of the innate immune system, which you are born with and acts independently against invaders. This type of response does not target specific invaders. Instead, it can attack a wide range of cells, healthy cells and non-healthy cells. Think bull in a china shop. Inflammation can also play a role in the adaptive or acquired immune system. This part of the immune system forms memory cells to wage a stronger secondary response upon reinfection a few days after exposure. Sometimes it overreacts or can't distinguish between self and non-self. Like in a case of mistaken identity, it can attack both. Some types of asthma can cause airway remodeling, where the permanent structure of airways changes. In this image, the non-asthmatic biopsy is on the left and fatal asthmatic biopsy is on the right. Smooth muscle mass increases. Mucus cell metaplasia, MCM, increases. MCM occurs when airway cells change into goblet cells that secrete excessive mucus, leading to mucus plugs that can further impair breathing. Airway obstruction can become irreversible. Lung function can decline. Airway remodeling has been diagnosed in patients as young as 2 years old, before inflammation is identified. The cause is not clear. Bronchial thermoplasty can remove excess smooth muscle. The different immune cells are involved in different types of inflammation. The most common type of inflammation in asthma is type 2 inflammation. Type 2 inflammation provides mucosal barriers, fights parasites, and triggers allergic reactions via Th2 T lymphocytes, immune cells called eosinophils, AGE antibodies, and inflammatory proteins called cytokines. The effects are systemic rather than local. It is often found in chronic persistent allergic asthma. Patients with a diagnosis of one type 2 inflammatory illness are at risk for developing another type 2 illness, such as eczema, food allergies, hay fever, and allergic asthma. There are also a couple of non type 2 inflammatory types. Type 1 inflammation fights pathogens within cells, such as viruses, bacteria, and cancer. It kills via Th1 cells, type 1 innate lymphoid cells, ILC1, and immune cells called macrophages. Hypersensitivity is often delayed and autoimmune. This type is often triggered by infections or smoking. It is diagnosed more often in adults. Examples include rheumatoid arthritis, type 1 diabetes, psoriasis, and multiple sclerosis. Type 3 or type 17 inflammation is severe. There are elevated white blood cells called Th17 cells and immune cells called neutrophils. This type of inflammation is prone to corticosteroid insensitivity and airway remodeling. These patients have a higher rates of exacerbations. It is very refractory where the inflammation is uncontrolled, even while following protocols. Examples include psoriasis and inflammatory bowel disease. To add to the confusion, some patients present a mixed type with both Th2 and Th17 activation. Risk factors for asthma do change in different stages of life. It is important that patients continue to monitor their condition and update their asthma action plan as needed. A definition. Early onset asthma develops in children. For infants and children, risk factors include maternal history, prematurity, C-section births, respiratory infections, exposure to air pollution and tobacco, and allergic polysensitization. Children tend to develop allergic asthma. Atopy is the genetic predisposition to allergic diseases characterized by an overproduction of IgE antibodies. This image shows the complexity of the genetics or genotypes. Late onset asthma develops after the age of 20. This is also called adult onset asthma. The risk for persistence into adulthood includes disease severity, allergic multimorbidity, and comorbidities. For late onset asthma, risk includes respiratory infections, tobacco smoke exposure, and occupational exposure to chemicals. Comorbidities include obesity, COPD, type 2 diabetes, sleep apnea, and cardiovascular diseases. Adult onset asthma tends to be more severe. A little more information about obesity. Adipose tissue releases cytokines, which increase inflammation. There can also be a decrease in overall lung volume and additional comorbidities, such as GERD. Asthma is often diagnosed based on patient history, clinical presentation, and test results. It may take a physician a lot of background information, test results, images, and even medication trial periods for a patient to receive a diagnosis, prognosis, and plan. In children under 5, a diagnosis is often based on symptoms and response to asthma medication. To help you follow the process, I'm going to describe some of the tests in order of invasiveness. Screening questionnaire. The Asthma Screening Questionnaire, ASQ, is a pre-interview screening for asthma. The test asks about symptoms. Physical exam and symptoms. Keep in mind a routine physical exam may be normal between asthma attacks. Physicians look for increased work of breathing, signs of inflammation, and allergic conditions such as eczema, nasal polyps, hay fever, or food allergies. The most common food allergy for asthma patients are peanuts, tree nuts, milk, eggs, shellfish, soy, wheat, and sesame. For patients with both asthma and food allergies, there is a severe risk of anaphylaxis, where breathing is severely impaired. This is life threatening and will need an emergency action plan, EAP. Asthma symptom questionnaires. The Asthma Control Test, ACT, and the Asthma Control Questionnaire, ACQ, assess control. The ACT is more simple and is self-administered. The ACQ is more sensitive and structured for a clinical setting. Both tests focus on the past 1 to 4 weeks. They ask about symptoms, impairment, and medication usage. The Asthma and Impairment and Risk Questionnaire, AIRQ, is a survey for asthma patients to assess current impairment and future risk for patients 12 and over. The TRACK, Test for Respiratory and Asthma Control in Kids, is a questionnaire for caregivers to monitor children under 5 over the course of 4 weeks. The Asthma Therapy Assessment Questionnaire, ATAQ, identifies barriers to control and outcomes. Pulmonary function tests can help diagnose asthma as well as determine how well symptoms are managed. Spirometry tests lung air volume and flow speed. Results are generally compared to expected results for someone of similar demographics. Forced vital capacity, FVC, is the total amount of air a person can forcefully exhale after taking a deep breath. FEV1 is forced expiratory volume in the first second. Normal FEV1 over FVC ratio for adults is 70 to 80%. Peak expiratory flow rate, PEFR, measures how fast a person can exhale air. The bronchodilator reversibility test is often performed during spirometry. A patient takes a medication that opens the airways, and then the test is repeated. A 12% increase in FEV1 indicates reversible airway obstruction, which is typical of asthma. The fractional exhaled nitric oxide test, FeNO, measures the amount of inflammation in the lungs. The peak flow meter measures how fast air can be forced from the lungs. This is not a diagnostic test. It is used at home to manage asthma and determine when to seek medical care. Methacholine challenge test, aka bronchoprovocation test, is used to see if your airways are sensitive to triggers. All of these tests do have normal ranges per age. Young children and seniors generally have lower normal lung capacity. Lung tests in children under 5 are not generally performed. Blood tests can help diagnose asthma as well as look for comorbidities. Arterial blood gas, ABG, measures pH, oxygen, and carbon dioxide in arterial blood to see how well the lungs transfer oxygen. Blood tests can also test for white blood cells, aka leukocytes, and their levels. Antibody tests. The IgE test can determine allergic conditions. The IgG test can help diagnose infections, immune deficiencies, or autoimmune disorders. ACTH, adrenocorticotropic hormone test, aka cocentropic stimulation test, measures the adrenal gland's response to check for dysfunction caused by treatment. ACTH controls cortisol in the blood. Cortisol is an anti-inflammatory steroid hormone. Physicians are looking for cortisol response of greater than or equal to 18 mgs over DL. Skin or blood allergy tests can identify triggers. Exercise tests measure lung function before and after exercise to see if exercise is a trigger. Exercise bronchoconstriction, EIB, is primarily a reaction to cold and dry air. It is not a direct allergic reaction, but can be triggered by allergies. Chest x-rays and CT scans of sinuses can rule out other conditions. All of these tests can help diagnose asthma, the type of asthma, and its severity. A couple of definitions. Asthma endotypes categorize underlying etiology, causes, and pathways of the asthma. Each endotype responds to different therapies and has different longer-term prognoses and complications. Asthma phenotypes present different triggers, symptoms, and clinical signs. Defining the phenotype can help predict disease outcomes. To review, we have different ways to categorize asthma: the genetic component, genotypes, the pathology, endotype, and the presentation, phenotype. Keep in mind that over the course of a patient's lifetime, the asthma endotype and phenotype may change, which may require an updated treatment plan. Recommendations for testing, classification, and treatment protocols for asthma differ at each stage of life. They are also specific for family and medical history, severity, level of risk, level of impairment, types of triggers, and comorbidities. Several agencies provide these guidelines to physicians and patients. They often share information and collaborate on projects. All of their information seems above board. The Global Initiative for Asthma, GINA, the National Asthma Education and Prevention Program, NAEPP, is part of the NIH. It is organized by the National Asthma Education and Prevention Program Coordinating Committee, NAEPPCC. The American Thoracic Society, ATS, European Respiratory Society, ERS, the Veterans Administration, VA. Some things to consider. From what I can tell, asthma rarely stays the same over the course of a patient's life. It can be diagnosed early and then change later in life. It can be diagnosed later after years of work exposure. It can be diagnosed along with other health issues. Asthma can be predictable one minute and unpredictable the next. Every body is different. To help clarify, I'm going to describe some of the endotypes, aka pathways of asthma. The most common type is type 2 high asthma, aka eosinophilic asthma. The symptoms of type 2 high asthma are the ones you would expect. It can occur in children or adults. It is the most common type in children, so early onset asthma. It can be allergic, which is atopic, or non-allergic. When you hear or read the term allergic asthma, that is a subtype of type 2 high asthma. Type 2 high asthma shows type 2 inflammation. Airway remodeling can occur. Eosinophils are high. High serum IgE antibodies, high T2 cytokines. This type responds well to inhaled corticosteroids, ICS, and targeted biologic therapies. In addition, these patients who also have COPD experience worse symptoms. There are a couple of specific subtypes. Aspirin exacerbated respiratory disease, AERD, aka Samter's triad. About 7 to 8% of all asthma patients have this type of asthma. It is non allergic. NSAIDs trigger severe asthma attacks, nasal polyps, and rhinitis. It typically presents in adulthood, so late onset. Treatments include avoiding the substances that trigger it, desensitization, and polyp removal. Allergic bronchopulmonary aspergillosis, ABPA, is a sensitivity to mold in asthma patients. The symptoms can include fever, brown plugged mucus that can lead to bronchiectasis. It is common in cystic fibrosis patients. Treatment includes corticosteroids and antifungals. Cough variant asthma, CVA, is a chronic cough lasting 6 to 8 weeks. It can occur in adults or children. It can progress to classic asthma. It is often triggered by cold air, exercise, cigarette smoke, and dust. Eosinophils and sometimes neutrophils are increased. It can cause airway remodeling. It is treated with inhaled steroids and bronchodilators. Type 2 low asthma, aka neutrophilic asthma, is more rare. Type 2 inflammation is low or absent in this type. This is generally type 1 inflammation. It may have polygranulocytic, low inflammatory cells, or a neutrophilic profile. It is often severe. It is often associated with smoking, obesity, or airway remodeling. This type of asthma is refractory to inhaled corticosteroids. Other methods are used to control it, such as weight management, smoking cessation, or bronchial thermoplasty. These patients are not generally candidates for current Th2 targeting biologic agents such as anti-IgE and anti-IL-5. There are types of asthma that don't fit neatly into the previous categories. Mixed granulocytic asthma, MGA, shows high eosinophils and high neutrophils. It is often associated with aging, so late onset or adult onset, obesity, or high blood pressure. It can be very severe or refractory. Airway remodeling is common. This type of asthma may be systemic, so there may be inflammation in the nervous system or even effects in the gut. It does not respond well to inhaled corticosteroids. Treatment targets both types of granulocytes, eosinophils, and neutrophils. Polygranulocytic asthma, PGA, is the most common phenotype in adults with stable asthma. So it is late onset. Poly refers to few granulocytes. Some risk factors are smoking, obesity, potential prior overuse of inhaled corticosteroids, and early life severe infections. It is frequently linked with type 2 asthma. There is a lack of airway inflammation. Neither eosinophils nor neutrophils are elevated. This type of asthma is generally chronic and mild. Macrophages and mast cells are elevated. Mitochondrial and metabolic genes seem to be overexpressed. It leads to airway remodeling. Typical PGA has a poor response to corticosteroids. Treatments focus on managing symptoms through long-acting bronchodilators, LABA, LAMA, bronchial thermoplasty, and lifestyle changes. Th17 high and Th1 high endotype shows neutrophilic inflammation with Th17 cytokines. It is often considered type 2 low, but can coexist with type Th2. It is often shows airway remodeling. It is non-allergic and non-T2 inflammation. It is driven by neutrophils and IL-17 levels. It is generally chronic, severe, and persistent. It is often triggered by infections. It is associated with cigarette smoking, air pollutants, and obesity. It has a reduced sensitivity to inhaled corticosteroids. Patients with this endotype have higher rates of hospitalization and longer recovery times. Treatment targets neutrophil-driven inflammation and specific cytokine pathways. Sometimes asthma is defined by extreme or sudden symptoms. Silent asthma, aka quiet chest, occurs when there is no sound related to the asthma. The airway obstruction occurs without the cough or even the wheeze. In extreme cases, it is called silent chest. Any type of physical activity can exhaust the patient. The patient may experience fatigue, shallow breathing, and pressure or pain in the chest. It is often triggered the same as typical asthma. A silent chest can result in a respiratory arrest. It is a medical emergency, so get medical help immediately if you suspect symptoms. Treatment includes corticosteroids or long-acting beta agonists, bronchodilators, and avoidance of allergic triggers. Although not common in the United States, there is also thunderstorm asthma. I would not be surprised if climate change increases the prevalence. Thunderstorms may quickly spread pollen and spores into the air. Patients suddenly experience symptoms, even those without a history of asthma. It is often treated by inhaled corticosteroids and antihistamines. If symptoms don't improve after 15 to 20 minutes, call 911. Many asthma patients will stay inside immediately after a thunderstorm. Something else to consider. Breathing exercises can be a complementary therapy for asthma patients. They do not replace daily maintenance or reduce medications, but they can improve quality of life by strengthening breathing muscles and improving lung efficiency. For asthma patients, the process of diagnosing and managing symptoms may feel stressful. Accepting assistance may provide some relief. Offering assistance may be welcome. Not every community has an asthma specialist close by. Sometimes patients need to travel for tests. Offering a ride can help. Another alternative is telemedicine, where practitioners can provide care and guidance when patients are not able to commute. If you are tech savvy, sometimes patients need help setting up telemedicine. Some caregivers can even text educational messages to family members of children with asthma. It is important to prepare for an upcoming appointment for asthma care. So provide a list of flow meter or other test results, triggers, episodes, medications, comorbidities, and questions. Each asthma patient needs their own personalized asthma action plan. This is a written sheet that shows individualized information needed to keep asthma from getting worse. It includes your emergency contacts and list of treatments. It can be provided to schools, workplaces, family, friends, and emergency personnel. In an emergency, a patient may not be able to communicate all this information. Patients can wear medical alert identification, such as a medical ID, that can provide their asthma information via directly engraved text or a QR code to link to their asthma action plan. A smartphone can also help. Smartphones have built-in or downloadable health apps that contain medical ID information that is easily accessible in an urgent situation. All of your asthma action plan information can be available right on your cell phone. Another way to plan ahead, you can take a CPR AED course to help an asthma patient before emergency personnel arrive. Classes are available through the American Red Cross and the American Heart Association. For patients that use inhalers, first aid for asthma is 4-4-4. First, sit the patient upright, leaning them slightly forward. Then help them administer 4 puffs of their inhaler using spacers if available. Encourage the patient to take 4 breaths of air per puff. Then wait 4 minutes for any improvement. Provide 4 more puffs if needed. If the patient starts to turn blue or becomes weak, call 911. On an agency level, the American Thoracic Society, ATS, will host its upcoming Respiratory Innovation Summit in Orlando in May 2026. This is a huge networking event that shares the latest respiratory research in treatments and therapies. The European Respiratory Society, ERS, will host their Congress World Meeting in Barcelona in September 2026. Evidently, this is the world's largest respiratory meeting. World Asthma Day is May 2026. More information can be found at ginaasthma.org. The theme this year is access to anti-inflammatory inhalers for everyone with asthma, still an urgent need. When we know more, we can do more. So stay diligent, check on your people. Please like, subscribe, and share this video. Share something useful because none of us have time for nonsense right now. Stay safe. I'm Wanda Frazier. This is Your Body and You.